Development and eruption of the teeth. Knowledge of the development of the teeth and their emergence into the oral cavity is applicable to clinical practice, anthropology, demography, forensics, and paleontology. However, dental applications are considered primarily. This chapter considers the development and eruption of the teeth, specific chronologies of both the primary and the permanent human dentitions, dental age, tooth formation standards, and applications to dental practice. For example, an understanding of both the chronology of dental development so that surgical intervention does not harm normal growth and the relationship between dental age and the effects of disease and environmental risks. The use of the terms primary and deciduous are often primary or deciduous reflects the difference of opinion about the most appropriate term to describe the first dentition in humans. Readers of the literature are able to deal objectively with both the terms. Clinical considerations. It must be kept in mind. Clinical considerations. It must be kept in mind that the dental practitioner sees in a normal, healthy mouth not only the clinical counts of the teeth surrounded by the gingival tissues, but also the number, size, but also the number, size, size, shape, position, coloration, and angulations of the teeth, the outlines of the roots of the teeth, occlusal contacts, evidence of function and parafunction, and phonetics and aesthetics. Most of the parts of the teeth that are hidden by the gingiva can be visualized radiographically. This can also be done by using a periodontal probe to locate the depth of normal or pathologically deepened gingival crevices, or a dental explorer to sense the surface of the teeth within the gingival crevice apical to the free gingival margin as far as the epithelial attachment of the gingiva to the enamel. In addition, in pathologically deepened crevices, tooth surfaces can be sensed as far as the attachment of the periodontal ligament to the cementum. Perhaps the simplest example of clinical exam perhaps the simplest example of clinical observation is the assignment of dental age or the assessment of dental development by looking into a child's mouth to note the teeth that have emerged through the gingiva. Perhaps the simplest example of clinical observation is the assignment of dental age or the assessment of dental development by looking into a child's mouth to note the teeth that have emerged through the gingiva. In the absence of other data, however, the number of teeth present are simply counted. When observations from clinical and radiographic sources of information are coupled with sufficient knowledge of dental morphology and chronologies of human dentition, the clinician has the foundation for the diagnosis and management of most disorders involving the size, shape, number, arrangement, aesthetics, and development of the teeth, and also problems related to the sequence of tooth eruption and occlusal relationships. For example, in figure 2.1a, the gingival tissues are excellent. However, figure 2.1a, the gingival tissues are excellent. However, the form of maxillary incisors and interdental spacing might be considered to be an aesthetic problem by a patient. To accept the patient's concern that a cosmetic problem is present and needs correction requires that the practitioner be able to transform the patient's idea of aesthetics into reality by orthodontics and cosmetic restorative dentistry. The situation in figure 2.1b demonstrates a periodontal problem, that is, localized gingivitis of gingival margin of the right central incisor, which is in turn a part of the result of the inadequate proximal contact relations of the incisors, leading to food impaction and accumulation of dental plaque and sometimes calculus. For the most part, however, it is the result of inadequate home care hygiene. Most conservative correction relates to the removal of irritants and daily tooth brushing and dental flossing, especially of the interproximal areas of the central incisors. Even so, the risk factor of the inadequate proximal contact remains. If the form of the tooth is not consistent with its function in dental arches, it is highly probable that non-functional positions of interproximal contacts will lead to the problems indicated in figure 2.1b. The form of every tooth is related to its position and angulation in the dental arch, its contact relations with the teeth in the opposing arch, its proximal contacts with adjacent teeth, and its relationships to the periodontium. An appreciation for the aesthetics of a tooth form and coloration is a requirement for the successful practitioner. Now, variability. It is not enough to know just the normal morphology of the teeth. It is also necessary to accept the concept of morphological variability in a functional, aesthetic, and statistical sense. Most of the data on tooth morphology are derived from the studies of samples of population of European American ancestries (EAS), and for example, as indicated in the section on tooth formation standards in this chapter, a variety of sequences in eruption of the teeth exist depending on the population sampled. Because of the Immigration Reform Act of 1965, it is most likely that future tooth morphology standards will reflect the significant change in the ethnic makeup of the population of the United States. that is, population samples of dentitions will reflect a greater variance. Uncommon variations in the maxillary central incisors, which are shown in chapter 6. You can see the figure 6.2, that is the uncommon variations in the maxillary central incisors reflect samples drawn from a population made up largely of European American ancestry. It is possible to accept the incisors. It is possible to accept the incisors shown as being representative of this population, or perhaps normal for the European or American ancestral population at the time sampled. A shovel-shaped incisor trait is found in a Caucasoid population only infrequently, that is fewer than 5%. However, it is one of the characteristics found in patients with Down syndrome, in which there is a trisomy 21 exists, and normally in Chinese and Japanese individuals, Mongolians and Eskimos. Statistically, then the shovel-shaped trait might be considered to be abnormal in the Caucasoid population, but not so in the Mongoloid populations. The practitioner must be prepared to adjust to such morphological variations. Malformations. It is necessary to know the chronologies of the primary and permanent dentitions to answer questions about when disturbances in the form, color, arrangement, and structure of teeth might have occurred. Dental anomalies are seen most often with third molars, maxillary lateral incisors, and mandibular second premolars. Abnormally shaped crowns, such as pec laterals and mandibular second premolars with two lingual cusps, present restorative and space problems respectively. This is one of the important bit. That is, dental anomalies are seen most often with the third molars, maxillary lateral incisors, and mandibular second premolars. Abnormally shaped crowns, such as pec laterals and mandibular second premolars with two lingual cusps, present restorative and space problems respectively. Patients who have disturbances such as the ones shown in figure 2.2, this is the figure 2.2, not only want to know what to do about it, but they also want to know when or how the problem might have happened. How the problem came about is the most difficult part of the question. Enamel hypoplasia is a general term referring to all quantitative defects of enamel thickness. Enamel hypoplasia is a general term referring to all quantitative defects of enamel thickness. They range from single or multiple pits to small furrows and wide troughs to entirely missing enamel. hypocalcification and opacities are qualitative defects. Hypocalcification and opacities are qualitative defects. The location of defects on tooth crowns provides basic evidence for estimating the time of the development of the defect with an unknown error and potential bias. The location of defects on the tooth crowns provides basic evidence for estimating the time of the development of the defect with an unknown error and potential bias. One method of establishing is provided in the section Tooth Formation Standards. In a cleft palate and lip, various associated malformations on the crown. In the cleft palate and lip, various associated malformations of the crowns of the teeth of both dentitions occur. The the coronal malformations are not limited to the region of the cleft but involve posterior teeth as well. The coronal malformations are not limited to the region of the cleft but involve posterior teeth as well. A number of congenital malformations involving the teeth are evident, with some the result of endogenous factors and others the result of exogenous agents. When a malformation has some particular characteristics, for example, screwdriver shaped central incisors, and is consistent with a particular phase of dental development, it may be possible to determine the cause of the disturbance. When a malformation has some particular characteristics and is consistent with a particular phase of dental development, it may be possible to determine the cause of the disturbance. This aspect is considered further in the section Dental Age. This is the figure 2.2 showing a hypoplasia of the enamel. In picture B, you can see defect in the tooth structure caused by trauma to the primary predecessor during the development of permanent central incisor. Chronology of primary dentition. The chronology of the primary teeth presented in Table 2.1 is based on the data derived from the tables 2.3 and 2.4 in the section Tooth Formation Standards. The universal numbering system is used in Table 2.1. The pictorial charts, that is figures 2.3 and 2.4, are not intended to be used as ideal standards of normal development. Their use is directed towards showing patients the general aspects of development rather than proving precise guidance for clinical procedures. This is the chronology of primary teeth. Here the universal numbering system is used, right? Universal numbering system is used. These were the figures 2.3 and figures 2.4. These are not intended to be used as ideal standards of normal development. Their use is directed towards showing patients the general aspects of development rather than providing precise guidance for clinical procedures. Development and eruption or emergence of the teeth. Here comes the main aspect of the lesson or chapter. Development and eruption or emergence of the teeth. Historically, the term eruption was used to denote the tooth emergence through the gingiva, but then it became more completely defined to mean continuous tooth movement from the dental bud to occlusal contact. Eruption means continuous tooth movement from dental bud to occlusal contact. Not all tables of dental chronologies reflect the latter definition of eruption, that is, continuous tooth movement from dental bud to the occlusal contact. However, the terms eruption and emergence are used here at this time in such a way as to avoid any confusion between the historical use of eruption and its more recent expanded meaning. Emergence of the primary dentition takes place or begins between the 6th and 13th months of postnatal life. Takes place between the 6th and 13th months of postnatal life. It takes from 2 to 3 years for the primary dentition to be completed, beginning with the initial calcification of the primary central incisor to the completion of the roots of primary second molar. Beginning with the initial calcification of the primary central incisor to the completion of the roots of the primary second molar. You can see in the figure 2.3. This is the figure 2.3. Beginning from the initial calcification of primary central incisor to the completion of the primary second molar. The emergence of the primary dentition through the alveolar mucous membrane is an important time for the development of oral motor behavior and the acquisition of masticatory skills. The emergence of the primary dentition through the alveolar mucous membrane is an important time for the development of oral motor behavior and the acquisition of masticator skills. At this time of development, the presence of teething problems suggests how the primary dentition can affect the development of future neurobehavioral mechanisms, including jaw movements and mastication. At this time of development, the presence of teething problems suggests how the primary dentition can affect the development of future neurobehavioral mechanisms, including jaw movements and mastication. Learning of mastication may be highly dependent on the stage and development of the dentition. For example, type and number of teeth present and occlusal relations. the maturation of the neuromuscular system, and such factors as diet, primary teeth, enamel organs you can see in the figure 2.5 do not develop do not enamel organs you can see in the figure 2.5 do not all develop at the same rate. Some teeth are completed before others are formed, which results in different times of eruption for different groups of teeth. Some of the primary or deciduous teeth are undergoing resorption while the roots of others are still forming. Some of the primary or deciduous teeth are undergoing resorption while the roots of others are still forming. Not all the primary teeth are lost at the same time. Some, for example, central incisors are lost 6 years before the primary canines are lost 6 years before the primary canines. Groups of teeth develop at specific rates so that the sequence of eruption and emergence of the primary or deciduous teeth is well defined with few deviations. Groups of teeth develop at specific rates so that the sequence of eruption and emergence of the primary or deciduous teeth is well defined with few deviations. Even so, for the individual child, considerable variation in the times of emergence of the primary dentition may occur. Even so, for the individual child, considerable variation in the times of emergence of the primary dentition may occur. The primary dentition is completely formed by about 3 years, by about age 3 years, and functions for a relatively short period before it is lost completely at about age 11. Before it is lost completely at about age 11. Permanent dentition is completed by about 25 years. Permanent dentition is completed by about age 25 if the third molars are included. We can see in the figure 2.3 and 2.4, right? Calcification of the primary teeth begins in utero from 13th to 16 weeks post fertilization. By 18 to 20 weeks, all the primary by 18 to 20 weeks, all the primary teeth have begun to calcify. Primary tooth crown formation takes only about 2 to 3 years from the initial calcification to root completion. Important bit. Primary tooth crown calcification takes only about 2 to 3 years from the initial calcification to root completion. Primary tooth crown formation takes only about 2 to 3 years from the initial calcification to root completion. However, mineralization of the permanent teeth is entirely postnatal, whereas mineralization of the permanent teeth is entirely postnatal, and the formation of each tooth takes about 8 to 12 years. The variability in the tooth development is similar to that for eruption, sexual maturity, and other similar growth indicators. Crown formation of the primary teeth continues after birth for about 3 months for the central incisor, about 4 months for the lateral incisor, about 7 months for the primary first molar, about 8.5 months for the canine, and about 10.5 months for the second primary molar. That is, the sequence is A B D C E. During these periods, first during these periods, before and after birth, disorders in shape, pigmentation, mineralization, and structure sometimes occur. During these periods, before and after birth, disorders in shape, pigmentation, mineralization, and structure sometimes occur. Fluorosis is considered later in this chapter. Now have a look over crown and root development. Dental development can be considered to have two components. One, the formation of crowns and roots, and two, the eruption of the teeth. Of these two, the former seems to be more resistant to environmental influences. The latter can be affected by caries and tooth loss. The formation of crowns and roots is more resistant to environmental influences, whereas the eruption of teeth is affected by caries and tooth loss. After the crown of the tooth is formed, the development of the root portion begins. At the cervical border of the enamel, that is, the cervix of the crown, cementum starts to form as a root covering of the dentin. The cementum is similar in some ways to bone tissue and covers the root of the tooth in a thin layer. In the absence of a succeeding permanent tooth, the root of the primary tooth may only partially resorb. In the absence of a succeeding permanent tooth, the root of the primary tooth may only partially resorb. When root resorption does not follow the usual pattern, the permanent tooth cannot emerge or is otherwise kept out of its normal place. In addition, the failure of the root to resorb may bring about prolonged retention of the primary tooth. Although mandibular teeth do not begin to move occlusally until crown formation is complete. Although mandibular teeth do not begin to move occlusally until the crown formation is complete, their eruption rate does not closely correlate with root elongation. After the crown and part of the root are formed, the tooth penetrates the alveolar gingiva and makes its entry, that is, emergence, into the mouth. Further formation of the root is considered to be an active factor in moving the crown towards its final position in the mouth. The process of eruption of the tooth is completed. When most of the crown is in evidence and when it has made contact with its antagonist or antagonists in the opposing jaw. The root formation is not finished. The root formation is not finished when the tooth emerges, because the formation of root dentin and cementum continues after the tooth is in use. Ultimately, the root is completed with a complete covering of the cementum. Additional formation of cementum may occur. Additional formation of cementum may occur in response to tooth movement or further eruption of the teeth. Also, cementum may be added, that is repaired and or resorbed in response to periodontal trauma from occlusion. The covering of the cementum of the permanent teeth is much thicker than that of the primary teeth. This is the figure 2.5 showing the enamel organ. You can see in picture in A. 1 indicates the beginning of the first primary molar. 2 indicates the bell stage of second primary molar. 3 indicates the dental lamina of the first permanent molar. 3 indicates the dental lamina of the first permanent molar. 1 for the primary first molar, 2 for the primary second molar, 3 for the permanent first molar. In picture B, you can see partially developed primary incisor and lingually you can see the developing permanent incisor. One includes clinical crown, dentinogingival junction, junctional epithelial attachment, developing tooth, that is permanent incisor.